Hi, my name is Dan, and I'm a mental health pharmacist. And today I'm going to be talking about the psychopharmacology of antipsychotics and how to select an antipsychotic. I have a few major objectives that I'm going to be covering today. So, I'm going to be talking about the appropriate indications for various medications. I'm going to review the role of antipsychotics in various disease states, and this won't be comprehensive. So, for example, I'm going to talk about schizophrenia, bipolar depression, delirium and dementia, and agitation, but I'm not going to be talking about um, all indications. So, an adjunct for depression's not on there, and then Tourette's disorder, tic disorder isn't on there. Then I'm going to talk about some of the major side effects in monitoring, and then I'm going to talk about some of the individual medications. I'm still going to group the first generation antipsychotics together, but then I'll go over each generation antipsychotic individually. Then a few slides on long acting injectables, and then a few cases, and that will finish up the presentation. First, I wanted to start with FDA approved indications. This first slide here is schizophrenia spectrum and other psychotic disorders. As you would guess, nearly all of the antipsychotic medications have that FDA approval for schizophrenia. I didn't include all of the first generation agents, but a lot of the most commonly used ones. And then as for schizoaffective disorder, only paliperidone technically has that FDA approval, but in practice, you'll see prescribers go off label frequently for schizoaffective disorder, and most of the antipsychotics have some degree of efficacy there. Next is bipolar related disorders. So, bipolar mania and bipolar depression. The ones with the blue font are medications that have some pediatric indication. It's of varying ages, but it's just for general knowledge that these have some pediatric indication. Next, we have depressive disorders, so an adjunct here. So, adjunct meaning in addition to an SSRI or an SNRI or another medication. And the ones that have this indication: Aripiprazole, Brexpiprazole, and Quetiapine, the XR version. A few other indications here are Tourette's disorder. So you'll see all of them have the blue font, so the pediatric indication. In practice, even though Pimizide's FDA approved, sometimes it's recommended just for that reason, in that it is FDA approved, but there's nothing special about it in particular, and it causes a lot of QTC prolongation. So if a patient has heart issues, you would be worried about that. So I don't recommend it, and I don't see Pimizide, but I just put it on here for the completeness sake. Next is Parkinson's disease psychosis, so pimavanserin, and then irritability associated with autistic disorder, aripiprazole and risperidone, and these are used a lot in pediatric patients with autism, and it's generally remains on label for this indication as well. So that covers the first objective. So we talked about the varying indications. Now I wanted to go into various disease states. And again, this isn't comprehensive. There are a few disease states that I won't be covering. I wanted to start with schizophrenia. So we'll go over some guidelines. We'll go over the CATIE trial. And I think both of these have important points that I wanted to make. First, here is the guidelines. So there's the World Federation's guidelines from 2012. There's the NICE guidelines from the UK 2014, Canadian guidelines 2017, and then the American guidelines most recently updated 2019. And my major point that I wanted to show here is that treating schizophrenia isn't generally like an algorithmic approach. Like, this is the one you use first. If that doesn't work, you try this agent. If that doesn't work, you try this agent. It's kind of like depression, where the guidelines just say, pick a first generation or a second generation antipsychotic. If that doesn't work, try a different first generation or second generation antipsychotic. If that doesn't work, try Clozapine. So the guidelines are pretty consistent here. And this isn't to say that the guidelines don't provide useful information. There is a lot of useful information in there. It's just not guiding you specifically to one particular medication over another. Next is the CATIE trial. So this is a famous New England Journal of Medicine trial from 2005. 1,400 participants. What really made it stand out is that they followed patients for 18 months. So a general FDA approval trial for a medication that the drug company supplies for schizophrenia is 4 to 8 weeks, so just 1 or 2 months. So this really goes into the prolonged course of schizophrenia, which is the reality that the patients face. They face this long-term illness. So I think it's best to study long-term. So it makes a lot of sense there. And that's probably why this trial became so famous. Interestingly, the primary measure outcome was time to discontinuation. So this is interesting because it takes into account efficacy. So if a patient's not improving on a medication, they'll discontinue, and also takes into account side effects. So if a patient's having side effects, they're going to discontinue it as well. So time to discontinuation covers both of those ends. The options for the trial, first generation was perfenazine. So the authors of this trial actively chose perfenazine over haloperidol. They were afraid haloperidol would have too many extrapyramidal side effects, or EPS. So they went with another first generation agent that has efficacy but less risk for EPS. The second generation here are good options: olanzapine, quetiapine, risperidone, and ziprasidone. Of note here, the dosing for olanzapine went up to 30 milligrams. Olanzapine has kind of a soft max at around 20 milligrams, especially outpatient. So 30 was a little bit higher, but some people do go that high, so it wasn't like unheard of. And the results are shown here. So again, the primary result they were looking for was time to discontinuation. The left graph says any cause, and the right graph says lack of efficacy. And you can see all of the agents are kind of clustered together, but olanzapine is the one in red, separated a little bit. So it did a little better than the other agents in that it was discontinued less. But remember, again, they did dose up to 30 milligrams, so a little bit higher. The major takeaways from the CATIE results is that most antipsychotics have comparable efficacy. And remember, this was an 18-month long trial, so pretty long when it comes to schizophrenia trials. Really high rates of discontinuation. So 74% of patients discontinued a medication before 18 months. So this again really ties into clinical practice. So a lot of patients will either not get the efficacy they're looking for, have side effects, not follow up and not be compliant. There's a lot of discontinuation in real life and in practice with schizophrenia. So it often takes a few medications and a few trials before things start to get a little bit better for the patient. So that covers schizophrenia. Next, I wanted to go into bipolar depression. Like when I was talking about with schizophrenia, if you choose a antipsychotic, most patients' psychosis will decrease. And if someone's in bipolar mania, if you choose most antipsychotics, the mania will decrease. But bipolar depression, it isn't as broad. So specific agents sometimes do better than other agents. So the ones that are FDA approved are generally what you want to stick with here, especially to start. The options are a combination pill of fluoxetine, olanzapine. The brand name here is Symbyax, but I never see the actual brand name Symbyax in practice. Providers will just do the cheap fluoxetine and the cheap olanzapine generic pills on their own. So as you can see from the picture, Symbyax comes in 6 milligrams and 25 milligrams, but in practice you would do 5 milligrams of olanzapine and then a 20 milligram tablet of or capsule of fluoxetine. Next is Quetiapine, also lorazepam, and then just in 2019, Cariprazine was also FDA approved for bipolar depression. The reason I bring this up, and I like to use an example here, is Abilify. So Abilify, or Aripiprazole, is FDA approved for bipolar mania, and it's FDA approved for an adjunct for depression. So then you would think it would be good for bipolar depression if you combine those, but a lot of the evidence is pretty negative. So one trial showed it was not better than placebo at week 8, so not giving you the long-term effects that you're looking for. And another trial showed that it didn't reduce relapse rates compared to placebo. So again, negative evidence there. Another example is ziprasidone, which also has some negative evidence in bipolar depression. So my points again of bringing up bipolar depression is really, at least initially, stick to the FDA-approved medications first. Next, I wanted to go into delirium and dementia. So we'll start with dementia. There is a black box warning for second generation antipsychotics in causing increased risk of death. This was based on a meta-analysis of 17 trials, and 15 of those trials did show that increased risk of death. And interestingly also is that 9 of these were unpublished. So unsure why the sponsor or whoever was writing those trials that showed the increased risk of death didn't publish it, but eventually that evidence did come out. And as you can see here, the risk is still somewhat low, but 3.5% versus 2.3%. In practice, so it's not just the second generation antipsychotics that cause that increased risk of death, so does the first generation antipsychotics. So in practice, you really want to be cognizant if you're choosing an antipsychotic for dementia. You want to have good reasons, you want to have really good documentation, you want to try other things first. So rule out other causes, try non-pharmacologic options, try even other pharmacologic options first. For nursing home patients, you have to have specific indications, specific doses, specific goals, what you're targeting, for how long, what dose, when can you decrease the doses. And even though that's specific for nursing home patients, that should really be done in all cases regardless. The most studied agents, Risperidone, olanzapine, Quetiapine, sometimes Aripiprazole as well. So this little table here shows just the overall evidence, and then if you want to split off psychosis or agitation. So a good starting choice is sometimes Risperidone, but really any of these agents can be used. Next is delirium. So if delirium does not correct with supporting measures, antipsychotics can be used. The first generation option here is haloperidol. Second generation is olanzapine, Quetiapine, and Risperidone. The SCCM, so Society of Critical Care Medicine, guidelines recommend against the use of haloperidol in delirium, but then if you look at the NICE guidelines from the UK, they recommend at most a week duration, so a week or less of either haloperidol or olanzapine. So these are all your options, but you want to use them for the shortest duration you can, really provide the other non-pharmacological options for delirium. And again, shortest duration, lowest dose that's effective, and try to get these patients off the antipsychotics soon. Final disease state is agitation. So if a patient has acute agitation or aggression, antipsychotics can be used. So this is typically seen maybe in the emergency room. Someone's coming in with either a mental illness or maybe polysubstance abuse, a few different substances. The emergency room isn't sure what the person was taking. So maybe it was something like PCP or bath salts, and the person's really agitated, at risk to hurt themselves or to hurt someone else. They'll give antipsychotics to help treat the acute agitation. So this table here shows some different options. One of the biggest takeaways of this table is that almost all of these have an IM option. So if a patient's that agitated and that revved up, it's hard to sometimes give them an oral option. So having the IM option that you can give them a shot version is what you're looking for here. Out of the first generations, haloperidol is the most common. It's commonly given with diphenhydramine, which is Benadryl, 50 milligrams IM, and then lorazepam, which is a benzodiazepine, 2 milligrams IM, and that combination is called B52. So in a really agitated person, giving those 3 IM injections can really help to calm them down. Chlorpromazine is often sometimes used as well, so that's a lower potency first generation. And then fluphenazine IM, I don't see all that frequently, but sometimes I do see it. The final first gen is loxapine. Loxapine staccato comes as an inhalation. It is an inhalation agent. It's REMS required, so it can cause bronchospasms, and you have to have the ability to intubate at your facility to choose this option. So I've never seen it used. It's not worth the risk. It's hard to get someone to inhale on like a it looks almost like a credit card. If they're really agitated, like here, inhale on this credit card, it's kind of difficult to do that. So again, the IMs are usually the best. Second generation, Risperidone is sometimes used, but this is only oral, so remember that. Even though there are orally disintegrating tablets, it's still oral. Olanzapine is probably the most commonly used here of the second generation, but remember that you can't give it with an IM benzodiazepine due to the risk of respiratory depression. So that takes away one other potential avenue. And ziprasidone, rarely used, but it does come as an IM option. I guess I shouldn't say rarely used, but sometimes less than some of the other options here. Okay, next I wanted to go into some of the side effects. So I'll start with dopamine blocking side effects, then we'll go metabolic, anticholinergic, and then a few others. So antipsychotics work in general by having dopamine blocking effects. So in the mesolimbic pathway, when you block dopamine, you decrease the positive symptoms of psychosis. So psychosis, hallucinations, things like that. But where we're good at selecting a receptor with medications, so we're good at selecting the D2 receptor, we're not necessarily good at selecting a specific pathway in the brain. So it goes everywhere in the brain and blocks dopamine in all the pathways that have dopamine 2 receptors. So this causes side effects in different areas. So mesocortical pathway, you can worsen the negative symptoms of schizophrenia. Tuberoinfundibular pathway, you increase prolactin, and we'll go into the consequences of that. And then nigrostriatal causes motor dysfunction, or EPS, which is extrapyramidal symptoms. So we'll skip the mesolimbic and mesocortical, but let's go into the tuberoinfundibular. So dopamine inhibits prolactin release. So when you block dopamine, prolactin rises. This causes hormonal issues, so hormonal-like issues, so gynecomastia, menstrual disturbance, loss of libido, sexual dysfunction, but it can also has the long-term risk of osteoporosis. The agents that are high risk here are strong dopamine blockers. So that makes sense. If you're blocking the tuberoinfundibular pathway, the dopamine there strongly, it's going to cause more prolactin to rise. So that risk here is with haloperidol and risperidone. But other agents have a really low risk. So things like Clozapine and Aripiprazole have a really low risk of raising prolactin. They may not even raise prolactin. Next is the nigrostriatal pathway. So this is what causes the movement issues that certain antipsychotics can cause. And some of these reactions happen quickly. So an acute dystonic reaction can take place within a day. Pseudoparkinsonism can take place over several days. Akathisia, which is this severe restlessness that people can develop when they're on certain antipsychotics, 90% happens within the first 2.5 months. So I remember a patient I had that had really bad akathisia, and we were rounding on her in the morning, and we were in this little treatment room, and she was sitting down, and she's like, "Can I just stand up for just a minute?" And I'm like, "No, I'll sit back down." And then she was like, "Can I just walk around the room for a little?" So she would take a few paces, get to the end of the room, take a few paces back. She was having really severe akathisia, and we had to stop her medication that she was taking due to that side effect. It's really uncomfortable for patients. I can't imagine. Finally is tardive dyskinesia, and this takes months to years to develop, but the effects can be permanent. So this is why we check an AIMS score at least once a year and check for those tardive dyskinesia symptoms to stop it from getting worse when it does start to develop, if it does start to develop. So with these side effects too, the highest risk is with, again, strong dopamine blockers. So that's where the nigrostriatal pathway is causing these side effects. If you're blocking dopamine strongly, you have a higher risk. So this comes into play with high potency first generation antipsychotics and risperidone. But then low potency and other second generation have less risk of this. Tardive dyskinesia I wanted to highlight again because these effects can be permanent. So the risk with a second generation is 20%. The risk with the first generation is 30%. But If you're on a second generation and have never had a first generation, your risk is only 7.2%. So this is the best case scenario. So again, especially if you have a young patient or you're worried about tardive dyskinesia, really be cognizant when you're choosing a first generation because you're increasing that total lifetime risk. Next is metabolic side effects, and you'll see here Clozapine, which is the most effective antipsychotic we have, has the highest risk here with olanzapine, which is sometimes considered the second most effective antipsychotic that we have. So that's unfortunate, but that's the way it is. So these two that cause some of our best effects have the most metabolic side effects, which mean like weight gain, insulin resistance, hypercholesterolemia. So we're able to sometimes manage these through dietary changes, exercise, other medications, but it is a risk that we have to follow closely. And then you can look at the medium and low risk agents. Next is anticholinergic actions, so dry mouth, constipation, sedation, ataxia. The high risks here are Clozapine and olanzapine again, so our most effective agents are also causing the anticholinergic actions, also Quetiapine, and then some low potency first generation antipsychotics as well. So you can think of like the pines, and then low potency agents could cause it like chlorpromazine. Some other side effects: neuroleptic malignant syndrome. So this is characterized by really high fevers, rigidity, autonomic instability, neurocognitive changes. So this is like a really severe emergent side effect of antipsychotics that have to be treated right away with like dantrolene and other skeletal muscle relaxants. And again, it's a medical emergency. Immediately discontinue anything that blocks dopamine. So not just antipsychotics, but sometimes like antiemetics or other agents that can block dopamine. You have to get rid of all of those right away. Other effects of antipsychotics is they can decrease the seizure threshold. This is most commonly seen with Clozapine at higher doses, so it's a dose-dependent effect, and chlorpromazine as well. So if you have someone on high amounts of Clozapine, sometimes you would check a level to see how high it is. Finally is QTC prolongation. So we'll check that especially with certain agents. Out of the second generations, the biggest offender is Ziprasidone. Out of the first generations, it's Thioridazine, which is almost never used anymore for that reason, and same with Pimozide. So then how do you monitor for these things? So for the dopamine blocking effects, administer an AIMS scale. So you're looking for any movements, tardive dyskinesia. Check for muscle rigidity, so check the muscles of your patients. Look for face and mouth movements while you're talking to your patients. Metabolic effects, weight, lipid panels, A1C. Check all their metabolic profiles, generally at least once a year, and you'll check the weight every time you see the patient. And then anticholinergic symptoms, you generally just have to ask the patient about symptoms, but especially pay attention to constipation. And if the patient's on Clozapine, that risk is more fatal. So ileus is more fatal in Clozapine patients than the ANC decreases that can happen. So that's a really severe complication with Clozapine treatment. So always ask about constipation, put a patient on a bowel regimen if they need to be on a bowel regimen, and just ask and follow that. Okay, so now let's go into some of the individual medications. We'll group the first generation antipsychotics together, and then we'll go into the second generations one by one. So the first generation antipsychotics, the side effect is related to potency. So high potency agents block D2 strongly, have weak anticholinergic effects, but then low potency agents have weaker D2 binding and strong anticholinergic effects. So it's kind of like you choose one or choose the other, but you'll get the opposite effect. How do you know if a first generation is low or high potency? This can generally be done in a simple way by looking at the number of digits that the average dosing is. So for example, haloperidol is 1 digit, so it's generally considered a high potency agent. Another option here would be like flufenazine. Medium potency agents, 2 digits, so a loxapine dose of like 50 milligrams would be normal, so 2 digits. And then a low potency agent dosing is normally 3 digits. So chlorpromazine is an example here. A starting dose is like 50, but it goes up to 100, 200, 300, higher than that. High potency agents to know are haloperidol, which is Haldol, or flufenazine, which is Prolixin. Both have a short-acting IM version and a long-acting injectable. So these can be used in situations where a patient's really agitated because you have that IM version, or it can be used in a more stable patient, maybe with compliance issues, in the long-acting injectable version. Or there's also, of course, the oral version. Both have a high potential for EPS, extrapyramidal side effects, because remember, these are strong dopamine blockers. Low potency agents to know, chlorpromazine or thorazine is the most commonly used one. There's the short-acting IM version, so again for agitation, but it doesn't have the movement issues like the high-potency agents, but it has the anticholinergic effects. And compared to other antipsychotics, a relatively high risk of seizures. The mid-potency agents are sometimes used, like in the CATIE trial, perfenazine, loxapine you'll sometimes use, but these are the most commonly used agents. Now let's go into the second generation. So I split them by the penes, the dones, and then the partial dopamine agonist. We'll start with the penes. So clozapine, this wasn't in the CATIE trial that we talked about, where basically all the antipsychotics were the same. Olanzapine's a little more effective, but clozapine has consistently shown that it's the most effective out of the antipsychotics. It has there's so many like individual facts with clozapine that are interesting and need to be known, so I included more on this slide than I generally do. Linear pharmacokinetics, so if you double the dose, you double the level. Decreases mortality, decreases suicidality. So it's one of only 2 medications that we have that have shown to decrease suicidality, with the other being lithium. Another point to make with clozapine is that it's highly anticholinergic in and of itself. So never add agents like benztropine or Benadryl or any anticholinergic because it already has that effect by itself. If you add benztropine or Benadryl or something like that, you double the risk of constipation. We already talked about how dangerous ileus is to clozapine patients. Next is smoking is a CYP1A2 inducer, which is a part of clozapine's metabolism. So smoking decreases levels by up to 50%. So if you have a patient in the hospital stable on a certain dose of clozapine and they're receiving nicotine replacement therapy like a patch, a gum, lozenge, and then that patient's discharged, then they start smoking again, their level can decrease by half and they can start developing symptoms again. So it's really important to pay attention to this. Seizure risk with clozapine, there's significant metabolic concerns, so you really monitor that closely. Lifestyle changes, diet, all pay attention to that. And then there is the biggest downside to clozapine is the weekly ANC monitoring, at least to start. So that does decrease down the road, but when someone started on clozapine, they're getting their blood drawn every week for the first 6 months. So below I have a receptor binding picture, and the 5-HT2A and the dopamine are fairly far apart. So it blocks 5-HT2A much more than D2. And also, as you can see, it binds to many different things. So it's generally considered like a dirty drug. Like it has all these different bindings. It's hard to nail down what makes clozapine so effective, or maybe it's just a combination of all these little receptors that it binds to. Next is olanzapine. So the normal dosing range, I put 5 to 30 here, but it might be more accurate to say 5 to 20. Sometimes inpatient, they'll go to 30, 40 milligrams, but that's generally shorter term. Outpatient, 20 milligrams is generally the max. What makes it unique, it's kind of like clozapine light. So it's structurally related, second most effective. A lot of the metabolic concerns, just like clozapine, also has the smoking interaction. Additionally, there is an LAI version called Zyprexa Relprev. It's very rarely used because you have to monitor the patient for 3 hours after the long-acting injectable is given. So that patient's taking up a seat in your clinic for 3 hours. So it's generally not used. There is an IM version, which we talked about, so for like agitation, um, but you cannot use it with IM benzodiazepines. Next to the pines is Seroquel. So what makes Seroquel unique is I've been told to think of it similarly to like a champagne chandelier that you'll sometimes see in like fancy movies or fancy weddings, I guess. And it's basically when you start with Seroquel and you just give a little bit of a dose, like start to pour in a little bit into the body, it's just binding to histamine receptors and causing histamine blockage. So it's not going to be effective for bipolar disorder. It's not going to be effective for schizophrenia at that dose. But then as you continue to add more in, it starts to overflow from the histamine receptors onto the second tier, which is serotonin receptors, 5-HT2A, 5-HT2C blockage. This is where you'll start to see its effects for an adjunctive for depression and bipolar effects. But it's still not at the level that it's effective for schizophrenia. You have to keep adding more in, and it pours over from the second tier into the third tier, which is finally dopamine blockage, D2 blockage. It's still relatively weak at D2 receptors, but you have to be at least 600 milligrams to really get consistent amounts of D2 binding. So that's the biggest thing I think about with Seroquel is how important dosing is. So dosing really matters with what effects you're going to expect to see. There's also significant metabolic concerns, significant sedation. Sometimes it's used for those reasons, though probably somewhat inappropriately. There's also a slight like prison or street value with Seroquel. It's hard to say exactly why. It seems to be like some sedation effects, some other sorts of effects, but outside of like prison populations or others, I don't generally see Seroquel abuse. The final pene is asenapine. So this agent is only available sublingual or as a patch, so it has extensive first pass metabolism. So the patch is new, I haven't seen it yet, but the sublingual version I have seen, sometimes in kids who have trouble swallowing or don't want to swallow. The biggest takeaway here, or to think about with asenapine, is treat it like a true sublingual. So it has to be absorbed through the oral mucosa. You want that sitting under the tongue, dissolving, not like eating or drinking foods right after. Really let it absorb. If it's swallowed, the GI tract breaks it down and it's not absorbed or utilized effectively. So it really has to be a true sublingual. Okay, next is the DONES. The most commonly used DONE is Risperidone. Brand name is Risperdal. What makes it unique is it's considered the most it's sometimes called the most typical of the atypicals because it has really strong dopamine blockage, so it's somewhat comparable to like a fluphenazine or a haloperidol. It causes prolactin elevation, which you would expect because it's a strong dopamine blocker. It still causes some weight gain and sedation though, so that's going a little away from some of the effects of the high potency agents. There's two long-acting injectables. Risperdal Consta is still somewhat commonly used, and then there's another version called Perseris, which is very rarely used at this point. Similarly to Risperidone, there's an active metabolite called paliperidone. The chemical name is 9-hydroxyrisperidone, so it's very similar to Risperidone. Its brand name is Invega. It's not hepatically metabolized, so it has minimal interactions, and it comes in an extended release pill. So it's kind of like a slightly better tolerated with less interactions version of Risperidone, but it's also more expensive, so that's the downside. There is a long-acting injectable. It's very common. It's called Invega Sustenna, and then if a patient's really stable and really doing well on that for a while, they can go to Invega Trenza, which is a once every 3-month injection, so only 4 injections a year. As I showed with the penes, how the 5-HT2A and dopamine blockage were really far apart, Now with the dones, they're getting closer together generally. So the D2 blockage is a little bit stronger relative to the 5-HT2A blockage. And again, just like clozapine, this picture here shows how dirty of a drug paliperidone is, as it binds to a lot of different receptor types. Next is ziprasidone or Geodon. What makes this unique is that it's weight neutral, which is really important in schizophrenia. So there's a lot of these agents have metabolic concerns, so it's nice to have a few options that don't have as much metabolic concerns. The downside to it being weight neutral is it has to be given with 500 calorie meal twice daily. So that's a lot of food to take in. If someone like adds meals to take into account the specific time they want to take the medication, that could be an additional 1,000 calories. So generally try to keep it with big meals that the patient's already taking. Another downside is that it has the most QTC prolongation of the second generation antipsychotics. So this little image here on the right shows 20-point tick mean change. So that can be clinically significant, of course. And then there is an IM version as well. Next is iloperidone or Fanapt. This blocks alpha-1 more than any other receptor, so more than D2, more than 5-HT2A. So it can have some blood pressure effects. It can cause some dizziness and things like that. It's not really used all that commonly. I can't think of the last time I've seen it because it has an intense titration. So imagine treating with someone with schizophrenia and saying, on day 1 you take 1 milligram twice a day, on day 2 you take 2 milligrams twice a day, on day 3 you take 4 milligrams twice a day, and then up and up and up, and it keeps titrating like that. So it can be a little intense for patients and providers to manage that and do that, so it's not commonly used. Next is lorazepam or Latuda. This is another weight neutral option, but it also must be taken with a meal. So in this case, only 350 calorie meal, and luckily this medication is once a day. So it can be thought of somewhat similar to ziprasidone in that it's weight neutral and the QTC, I'm sorry, not the QTC, the calorie meal. It's different than ziprasidone in that this doesn't have a QTC warning, whereas ziprasidone does. I generally see Latuda used for bipolar depression more than schizophrenia. So it is FDA approved for bipolar depression. That's where you'll probably commonly see it as well. Next is the partial dopamine agonist, so just 3 here. So we started with the penes where 5-HT2A and dopamine were really far apart, then the dones brought them closer together, and now they've swapped over with the partial dopamine agonist in binding strength. So these bind really strongly to D2 compared to 5-HT2A, but remember, they're not D2 blockers, they're partial agonists here, so the mechanism is different. What makes it unique? Pay attention again to the dosing range, so kind of like when we talked about Quetiapine, low doses for depression, high doses for schizophrenia and bipolar mania. It's a partial dopamine agonist. It has low sedation and weight gain. It has a long half-life, so 75 hours, and there's 2 long-acting injectable versions available. There's Aristata and Abilify Maintaina, and both are fairly commonly used at this point. Another point to make about its strong D2 binding is you don't want to use more than one antipsychotic together almost always, unless if it's clozapine augmentation or unless if the patient has tried really a lot of different things. But aripiprazole or really any of the partial dopamine agonists aren't a good choice for antipsychotic polypharmacy because they do bind so strongly to D2 that something else like Haldol might have trouble binding to D2 or Risperidone might have trouble binding to D2. So it's a bad option for antipsychotic polypharmacy. That being said, they all are. Next is brexpiprazole or Rexulti. So think of this as like a less studied aripiprazole that's only approved for schizophrenia and depression adjunct. So it's like a less studied, less widely approved version of aripiprazole, and again with a long half-life. And you can think of Cariprazine or Vraylar kind of like the same thing, a less studied, a narrower FDA-approved version of aripiprazole. So this is approved for schizophrenia and then bipolar mania and depression, but doesn't have that depression adjunct FDA approval. Again, this has a long half-life with an active metabolite that has a really long half-life, so 2 weeks. So this could mean that when you make dosing changes, they might take some time to manifest. So a patient might not notice any difference for a week or so out of the dosing change. So be patient with this medication and all of the partial dopamine agonists that have this long half-life. For completeness sake, I did include 2 more, so lumateperone and pimavanserin. Lumateperone's new. I've never seen it used yet. Its brand name's Caplyta. What makes it unique is it blocks 5-HT2A 60 times stronger than D2, and it caused weight loss at 1 year, which is potentially could be really beneficial for certain patients. But it does have this like Goldilocks dosing. So one trial compared 28 milligrams to 42 milligrams, and only the 42 was effective. Another trial compared the 42 to the 84, and only the 42 was effective. So it's like too little dosing doesn't work, and too much dosing doesn't work. You need to be right in the middle. Also, another one of its trials didn't show efficacy at any dosing range, so it might be on the weaker end of efficacy. But like I said, it's new, so I'll reserve most judgment until I know more about it, see more studies, see it used in practice. Final one is pimavanserin or Nuplazid, and this does not affect dopamine at all. So that means it doesn't have the extrapyramidal symptoms, which is what you want for this approval, which is Parkinson's disease psychosis. So you don't want to make anyone stiff or have tremors who has Parkinson's disease, so this doesn't affect dopamine. It's an inverse agonist at 5-HT2A, which is a unique mechanism. And like I said, it's only approved for Parkinson's disease psychosis. Next, let's talk about how to pick an antipsychotic. So remember from the guidelines, they don't tell you a specific agent to pick. It just says pick a first generation or a second generation to start. So you generally pick based on side effects and indications. So also remember that certain medications are only FDA approved for certain conditions. Good starting options for psychosis, maybe I shouldn't say good starting options, but commonly used starting options, not that they're bad, but are Risperidone, olanzapine, and haloperidol. Clozapine for refractory cases, so generally after 2 trials of other medications, or if a person's really suicidal or violent, it can be sooner than 2 other trials. And then long-acting injectables for compliance issues. Next, I wanted to touch on how to switch medications. So as you saw from the CATIE trial, 74% of patients had to switch medications within 18 months. So this is going to be something that happens fairly commonly. Your options are to cross-titrate or do a direct switch. So here's an example of switching to Risperidone. So remember, Aripiprazole has strong D2 binding and has a long half-life. So you would just stop Aripiprazole, start Risperidone at a lower dose, and then titrate it over time. Then with other dones, so ziprasidone, lurasidone, they're similar structurally to Risperidone, so you can do a 1-week cross titration, so relatively quick. And then with medications that are pretty different, so like Quetiapine, Clozapine, so the pines in this case, you would do a longer cross titration. So the 4-week cross titration, nice and slow, take your time. So the major points with how to switch medications, if it's something really similar, like paliperidone to Risperidone, you can do it quickly. If it's something very different, like Risperidone to Clozapine, you want to do that switch more slowly. So that's the major point I wanted to make there. A few slides on long-acting injectables. So one point to note here is they can be used first line. So you don't have to reserve this for a patient who's tried and failed a few other options. All you have to do is determine oral tolerability and efficacy, like the patient's doing well on this oral medication, you can go to a long-acting injectable right at that point. One study I wanted to highlight is that it increased compliance from 29% of patients on an oral antipsychotic to 37.5% compliance on a long-acting injectable. And you might think that doesn't seem that good or that different, so 29% to 37.5. But when they looked at hospitalizations and hospitalization days, it was really effective. So decrease the number of total hospitalizations from 1484 to 958 and decrease hospital days by half. So think of all the time that's saving the patients and the doctors. Think of all that money that's saving the healthcare system, and think of all the beds that's keeping open for other patients. So long-acting injectables really should be thought of. Here are the options available. They're all pretty common, except for the two that I crossed out, olanzapine and Perseris. I don't see that frequently, but the rest you will see. Finally, I had a few cases that I wanted to talk about. First case, 25-year-old male brought into the emergency room by police after he was found on a busy road yelling at cars passing by and swinging a baseball bat. He is pulling on his restraints, agitated and yelling. Which medications would you recommend? So this is the case of a young person coming in. You don't really know much of the medical history. There's a lot of agitation. This patient's at risk to hurting themselves, hurting other people. So what would you recommend? The major point I wanted to make here is think of this as like an agitation case. So you want to use an IM option generally. Risperidone is an option that's oral only, but you might have your nurses mad at you that they got the medication spit back in their face. So this might be the case where, unless the patient calms down a bit, you want to use an IM option. The most commonly used one here would probably be haloperidol or that B52 combination that I talked about, but any of these options are okay that I provided. Case 2, 40-year-old male presents with a diagnosis of schizophrenia after being stable on olanzapine 20 milligrams for 3 years. He has gained 30 pounds, was diagnosed with prediabetes, and wants to know if he should switch medications. What do you recommend? So the first thought here might be to switch right off the bat. He's gaining weight, he has prediabetes, he's having these metabolic concerns. But what I would do first is really dive into the medication history. So is this olanzapine the first antipsychotic that the patient's tried, or has he been on all these other ones and he's finally stable for this 3-year time period? If that's the case, then I'm really going to fight to keep the olanzapine and really dive into diet changes, exercise changes. Maybe you can sometimes add metformin in certain cases with antipsychotics, something like that, and really fight to keep the patient on olanzapine. But say in this case the patient has only tried antipsychotic-wise olanzapine, you might be more inclined to switch. And there's lots of options that have less weight gain than olanzapine. So aripiprazole, brexpiprazole, lorazepam, ziprasidone, minimal weight gain there. And then many options have less weight gain but still have some weight gain, like risperidone. So you have a lot of options. So the major point of this case was really dive into the history and see, don't jump to switch right away, was the major point. Case 3, 79-year-old female is admitted to the hospital for failure to thrive. She has a history of dementia, but her baseline is unclear and has been severely agitated, screaming, and pulling on her lines. What do you recommend? So what you would recommend here could be an EKG. You want to rule out any other medical concerns, so really do a good history, some blood work maybe. If you do decide to use an antipsychotic in this patient, some options would be risperidone, olanzapine, quetiapine. Remember to use at the lowest dose for the shortest duration you can, and target specific symptoms and really document things well. So there is that increased mortality risk. Notify the family exactly what your goals are and why you're choosing this. But antipsychotics can be and are used for some of these severe symptoms related to dementia. So that is an option. My references can be seen here, and thank you so much for listening.